Non-pharmacological treatment review for the PMHMP ANCC exam. And this is going to be a pretty close following of Chapter 8 of the Purple Book, which is the PMHMP Review and Resource Manual, 4th edition. It's going to be split up into two parts, and I'll explain at the end. This is going to be part 1. This chapter discusses non-pharmacological interventions such as individual psychotherapies, group therapy, family therapies, and complementary and alternative therapies. Because medications alone do not treat a person's environmental or interpersonal stressors and his or her responses to these stressors, an integrated approach is the most beneficial in treating mental illnesses. Although some people seek counseling for self-discovery, the most common issues for individual therapies will be discussed in the next slide. And they are losses, interpersonal conflicts, symptomatic presentations such as panic, phobias, and negativity, unfulfilled expectations at life transitions, character issues such as narcissism or aggressiveness. So character issues or character or personality issues. Confidentiality may be broken when there's an increased potential for self-harm or harm to others, abuse of a child, older adult, or a disabled person, or when the therapist determines that the patient needs inpatient hospitalization, or when the client requests that information be shared with a third party. The individual therapies that will be discussed is the psychoanalytic therapy, cognitive therapy, behavioral, dialectical, existential, humanistic, interpersonal, and EMDR. Psychoanalytic therapy originated by Sigmund Freud, who believed that behavior is determined by unconscious motivations and instinctual drives, promotes change by development of greater insight and awareness of maladaptive defenses. It attends to past developmental and psychodynamic factors which shape present behaviors. Cognitive therapy originated by Aaron Beck, and it purports that external events do not cause anxiety or maladaptive responses. It states that a person's expectations, perceptions, and interpretations of events cause anxiety. This is cognitive therapy. And cognitive therapy allows clients to view reality more clearly through an examination of their central distorted cognitions. The goal of cognitive therapy is to change clients' irrational beliefs, faulty conceptions, and negative cognitive distortions. And this is what I just said, but I forgot to flip the slide. So I'll just repeat it. Goal of cognitive therapy is to change irrational beliefs, faulty conceptions, and negative cognitive distortions. Behavioral therapy, originated by Arnold Lazarus, focuses on changing maladaptive behaviors by participating in active behavioral techniques such as exposure, relaxation, problem solving, and role-playing. Dialectical behavioral therapy, originated by Marsha Linehan, commonly used for borderline personality disorder. It focuses on emotional regulation, tolerance for distress, self-management skills, interpersonal effectiveness, and mindfulness. There is an emphasis on treating therapy-interfering behaviors. DBT goals are to decrease the following behaviors: suicidal behaviors, therapy interfering, emotional reactivity, self-invalidation, crisis-generating behaviors, decreasing passivity. DBT aims to increase the following two behaviors: realistic decision-making and increase accurate communication of emotions and competencies. Existential therapy originated by Viktor Frankl, a philosophical approach in which reflection on life and self-confrontation is encouraged. It emphasizes accepting freedom and making responsible choices. Existential therapy states that a basic dimension of humans includes finding meaning and purpose in life. Why am I here? What is my purpose? The goals of existential therapy are to live authentically and to focus on the present and on personal responsibility. So live authentically, focus on the present, and personal responsibility are the goals of existential therapy. Humanistic therapy originated by Carl Rogers, also known as person-centered therapy. The concepts of humanistic therapy include self-directed growth and self-actualization. People are born with the capacity to direct themselves toward self-actualization. Each person has the potential to actualize and find meaning. Interpersonal therapy was originated by Gerald Klerman and Myrna Weissman. It's an evidence-based therapy with focus on interpersonal issues that are creating distress. It's time-limited, active, focused on the present, and on interpersonal distress. It was developed to treat aspects of depression and also used for bipolar, substance use, and eating disorders. It is if interpersonal therapy is effective for both adults and adolescents. Eye movement desensitization and reprocessing, EMDR, was originated by Francis Shapiro. It is a form of behavioral and exposure therapy. It involves the use of bilateral stimulation, moving of the eyes back and forth, alternating tapping on hand or knee, or sounds in ears. EMDR is most commonly used in post-traumatic stress disorder. The goal of EMDR is to achieve an adaptive resolution. EMDR has phases. The following three are not an all-inclusive list of the phases, but they are the only 3 phases that are included in this EMDR therapy section. Therefore, I'll also limit our video and study topics to just include these three. So desensitization happens at the beginning, somewhere in the middle happens installation phase, and then at the end comes a body scan. The desensitization phase of EMDR happens at the beginning. The client visualizes the trauma, verbalizes the negative thoughts or maladaptive beliefs about the trauma, and remains attentive to physical sensations. This process occurs for a limited time while the client maintains rhythmic eye movements. They are then instructed to block out the negative thoughts, to deeply breathe, and then to verbalize what he or she is thinking, feeling, or imagining. During the installation phase, the client installs and increases the strength of the positive thought that he or she has declared as a replacement for the original negative thought. During the body scan, the client visualizes the trauma along with the positive thought and then scans their body mentally to identify any tension within. Now we're going to move on to group therapy. The benefits of group therapy are it increases insight about oneself, increases social skills, is cost-effective, and it develops a sense of community. Urban Yalom was the first person to put a theoretical perspective on group work and identified 10 therapeutic factors that differentiate group therapy from individual therapy. And these are installation of hope, universality, altruism, increased development of socialization skills, imitative behaviors, interpersonal learning, group cohesiveness, catharsis, existential factors, and corrective refocusing. The installation of hope phase, participants develop hope for creating a different life. Members are at different levels of growth, thus they gain hope from others that change is possible. Universality. Participants discover that others have similar problems, thoughts, or feelings, and that they are not alone. Altruism. Altruism results from sharing oneself with another and helping one another. Increased development of socialization skills. New social skills are learned and maladaptive social behaviors are corrected. The group can provide a natural laboratory for this to happen. Imitative behaviors. Our participants are able to increase their skills by imitating the behaviors of others. Interpersonal learning. Interacting with others increases adaptive interpersonal relationships. Group cohesiveness. Participants develop an attraction to the group and other members as well as a sense of belonging. Catharsis. Participants experience catharsis as they openly express their feelings which were previously suppressed. Existential factors. Groups enable participants to deal with the meaning of their own existence. In corrective refocusing, participants re-experience family conflicts within the group, which allows them to recognize and change behaviors that may be problematic. Group therapy sessions are organized into phases. The 6 group phases are pre-group, forming, storming, norming, performing, and adjourning. During the pre-group phase, the leader considers the direction and framework of the group, the purpose, goals, membership criteria, membership size, pre-group interview, and informed consent. During the forming phase, members are concerned about self-disclosure and being rejected. Goals and expectations are identified and boundaries are established. The development of trust and rapport is very important. During the storming phase, members are resistant and may begin to use testing behaviors. Issues related to inclusion, control, and affection begin to surface. Leaders' tasks are to allow expression of both positive and negative feelings, assist the group in understanding the underlying conflict, and examine non-productive behaviors. And this is during the storming phase. During the norming phase, resistance to the group is overcome by the members. A strong attraction to the group and others emerges. Open and spontaneous communication occurs, and the group norms are established. During the performing phase, the group's work becomes more focused. Creative problem solving and solutions begin to emerge. Experiential learning takes place, and the group energy is directed toward completion of goals. And this is during the performing phase. During the adjourning phase, preparation is made to end the group. Remember that the work of termination begins during the first stage of the group. So, during the adjourning phase, both the members and the leaders express their feelings about each other and the termination. A discussion and overview of what has been learned, as well as what issues still need to be worked on, takes place during the adjourning phase. For reminiscence therapy, we're going to conclude with reminiscence therapy. So this is characterized by a progressive return to memories of past experiences. It's often used with older adults, and it enables participants to reach for meaning in their lives and strive for some resolution of past interpersonal and intrapsychic conflicts. This concludes part 1 of the non-pharmacological treatment chapter of the Purple Review book. The final 2 categories that we'll discuss in the second part of the video, or the second video, will be family therapies and complementary and alternative therapies, and that should conclude that chapter.